so much for gives me opportunity for to delivering this topic at this platform. So as introduced about myself, I am Birendra Pratap Singh from Dr. Shrav Eye Hospital. So today my topic is to presenting here the examination of children in the vision center settings. So as all we know that the vision centers are working on the three major component. 3R basically. 3R is the one is the refraction, second one is the recognize the pathology, and third one is the referral. So pediatric eye examination is very different from the adult eye examination. So through this session, I will able to cater these some key points for learning objectives. You will able to understand after this session why we have need to special care during the examination of children compared to adult, and what are the key history taking examination for the pediatric age group population, and techniques of gross ocular assessment in the pre-verbal age group children. And there are some different guidelines for prescribing glasses in the adult compared to the in children compared to adult. As all we know that why we need to special care for the children. So also as all we know that the clear vision is the most important factor for the overall development of the child. So there is the uncorrected refractive error might lead to the amblyopia and as well as the squint. If it detects early, so the recovery rate is higher. If we correct the refractive error, we can overcome both these conditions because the plasticity of the visual system at this age is very higher. So this is very mandatory. You have need to check the child appropriately. So what are the key components? As yesterday, Miss Revati also covered about the history taking at the vision center level. But for perspective of the pediatric population, here the green highlighted some points like general health history, prenatal, postnatal, perinatal, and birth history, family ocular history, and the developmental history. So these are some key components for the pediatric evaluation. You have need to check and ask these histories related to the kids with the parents, like the perinatal, prenatal, postnatal, birth history. Birth history, for example, if it's born before the 9 months of gestational age, so it can be risk factor of the developing the ROP. And in the NLDO block is also the some infection during the pregnancy period, and some of the hereditary disease like the congenital cataract and the myopia and glaucoma. There are some various pathologies related to the some hereditary disease, and some developmental history is also the most important factor, like the delayed developmental milestone is there if there is any case of the cortical visual impairment condition. So challenges in the pediatric refractive management is the early screening and correct vision assessment at that remote location, and the accurate refraction is the most common major challenges, and association of establishment with correlation with the refractive eye condition, and compliance because these vision centers are situated in the rural community where the access is very low, and in that category population doesn't accept very easily your advice at that segment. So you have need to in-depth counseling to the parents to ask their kids to using the spectacle or taken that treatment appropriately which advised by you, and also to ask the parents what is the importance of follow-up for the kids, especially like we have already explained about the amblyopic genic factor regarding to the vision. So different phases of the eye examination. One is the pre-verbal age group, second one is the verbal age group, and third one is the school age group. So these are some common tests for the visual acuity assessment in particular age group. That pre-verbal age group 0 to 2 years, verbal age group 3 to 5 years, school age group children is more than 6 years of age. So in school age group children is very easy to assess the visual acuity level. It is looking like a adult examination. But in the verbal age group, it's also slightly typical compared to the school, but in the pre-verbal is very typical task. So I will explain about the how you can assess that pre-verbal age group child in the visual assessment section. So these are some common tests which we applied in our vision center settings, like pupil reaction, fixing and following light, red reflex test, corneal light reflex test, and near retinoscopy. So one by one, I will explain about these tests. What is the relevance of these tests? Like pupillary reaction. This test is basically you can apply it for the age group of 0 to 3 months. You will check the pupillary reaction. So if there is pupillary reaction is normal, that means the eye and brain connection is slightly growing and developing. Another test is the fixing and following light with central steady maintained, where the central steady maintained, central stands for is the corneal light reflex test is central and symmetrical in both eyes. When you are moving the torchlight in different direction, so it will be in the central of the pupillary area. Steady means the small target in front of the child moves slowly. Is their movement is steady or any jerky movement is there, that means unsteady fixation is there, then you have to mention it. Similar in the maintain category, ability to keep eye fixated on the target, whether either eye is covered. So it can be tested on the monocular basis assessment. Another test is the Bruckner's test, that is called the red reflex test. So this test is conducted on the 50 centimeter from the child. And so you can use, that is one innovative device is arc light, or in practice you can use the ophthalmoscope. So you can detect the presence of the any ocular abnormality in that kind of kids. So you have need to just symmetrical reflex. If there is symmetrical reflex coming from the both eye pupil, so that means that this is the normal condition of the eye. And asymmetrical refractive error, you can see here, there is the upper side reflex is slightly brighter compared to the lower side. In this eye, you can see the lighter in the lower side. You can see in the left eye is having the dull reflex. In this eye, you can see the yellow or white reflex in the left eye. So these are the some posterior segment related condition. In middle of two images indicates that the refractive error condition. One is the hyperopic cases, second one is the myopic cases. So these are the tests. Just to gross idea about that particular age group, you can screen those kids appropriately. Time being, they can accept the treatment in appropriate time to reduce the risk factor of some dangerous kind of pathology. Another test is the corneal light reflex test, to check the ocular alignment of the both eye, to look the symmetry of the both eye pupillary reflex. So you can see here in image 1, there is the central image is appearing in the pupillary central margin. So this is the normal condition. When you will see these conditions where the slightly central reflex is slightly displaced to the temporal side, whereas the isotropic condition means the eye moves towards the laser side. In second image, you can see the central light in the left eye image displaced towards the nasal side. So it is the exotropic or divergent squint condition. And one another test is indicated for the pediatric age group population in the non-pre-verbal child. You can just estimate the roughly gross idea about the refractive error status of that particular child. When he is not cooperating, then you can assess just 50 centimeter. You can switch on the retinoscope and ask to focus on that retinoscope light. Baby will see there, and you can just grossly neutral the reflex, and which value you will be found that gross value, then you can detect the 1.5 for the working distance rather than 2 diopter, because here we have target the illuminated target. So there is no tonus effect. So 0.75 we will not detect. So we will detect only the 1.25. You can get the final refraction value on the calculation of that. So these are some major concerns and challenges. Refraction very difficult to uncooperative children, and also to be in that segment vision center, you have need to decide on the behalf of retinoscopy, are we prescribing, we have need to prescribe fully corrected or partially correction. Mean if you will fully corrected which you got, maybe it will hamper their hematophysiation process. Similar, what kind of the cycloplegic drops to be used for the cycloplegic refraction? This is also a major challenge at the vision center segment, and what to prescribe so that child doesn't become amyloid. So all points you have need to keep in mind before prescribing any glasses to the children. So these are some major common points we have need to keep in our mind before prescribing the glasses. Is the refractive error within the normal range of child? Will the particular child refractive error will be emmetropized? Will the prescribing glasses interfere with the normal process of emmetropization? Will this level of refractive error disrupt the normal visual development of functional vision? Will the prescribing spectacle improve the visual functional or functional vision? So in this slide, I am explaining about what kind of cycloplegic drugs to be used in particular age group. If the patient having no squint condition and you have find out some gross refractive error value is more than 2 diopter, then you have need to do the atropine diffraction till the age of 1 year. After that, you can use the cyclopentolate drop for the cycloplegic diffraction. In case of isotropic condition, you can use up to the 7 years, 1 to 7 years age group, atropine eye ointment 1% for 3 days application as per need. And in exotropic condition till the age of 2 years, you will use only the atropine. Then you can use the cyclopentolate for till age of 7 years, from 3 to 7 years. So these are some prescribing guidelines without squint. Please focus on that. If the patient having no squint till the age of isometropic condition, both I am getting the equal or 0.5 difference refractive error, then up to 1 year of age, we will not prescribe the myopic up to 5 diopter, hyperopic up to 6 diopter, and astigmatism up to 3 diopter. More than that, we have need to partially correct. 1 to 2 years, the range will be slightly decreasing according to the American Academy of Pediatric Ophthalmology guidelines. And for the anisometropic condition, where the difference is slightly more than 2 diopter, then you can myopia up to 2 diopter, hyperopia up to 1 diopter, and astigmatism up to 1 diopter. You don't have need to prescribe. Beyond that power, if you are getting in the difference of both eyes, you have need to prescribe for the kids. And with squint, that was without squint. These are the conditions with squint. If the patient having the squint condition, that means the refractive error condition is isometropic in both eyes, but the patient having exotropic, that means divergent squint. So in myopia, you will correct the fully corrected, which minus number you are getting, you have need to advise after the cycloplegic fully correction, only detect the working distance. In hyperopia, under corrected by 3 diopter value up to 2 years, then you can prescribe the fully correction. In isotropic condition, you have need to use the cycloplegic guidelines and also advise the full correction to the kids up to the age of 7 years. So these are the guidelines for prescribing spectacle for the kids. Now, just brief about that these slides. Isotropic condition, we have need to prescribe the hyperopia full cycloplegic refraction to the patient. So at least they will stimulate their accommodation. Then automatically that convergence will be relaxed. They will relax the accommodation with more plus power. So automatically that squint will be grossly corrected by the spectacle correction. Myopia according to the visual demand. And in exotropic cases, you can fully correct the myopic where the accommodation demand to be raised by the minus power. So automatically exotropic eye will be slightly convert. So it will be corrected by the spectacle correction. Hyperopia according to the visual demand, that means hyperopia you have need to under correct. And in case of nystagmus, you will prescribe the glasses in the null zone. So maybe in the vision center settings, you will not prescribe the nystagmus and exceptional cases like CBI because they have need some extra attention and some different type of charts to evaluate the visual acuity level. So this will be slightly different. So these are some specific guidelines from my side. And thank you so much. If any query, please let me know.